We move from 2 babies to 3 babies, and the purpose of this lecture is to point a little bit to the difference in how we manage these twins. And as you probably know, one of my hobbies is looking at monochorionic placentas, and this is a placenta of a monochorionic triplet. And it's just to show how amazing nature is. So you have the 3 cord insertions here. They were actually triamniotic, and they ended with 3 healthy babies around 33 weeks. And as you can see, all 3 babies are connected through vascular anastomosis. So it's really amazing how they managed to keep balance amongst the 3 of them. Now, just what I'm going to address is the epidemiology of triplets, and then their typical features, the different types, and how we manage them. So, just to remember Helen's law. It's a law in biology that allows you to calculate the natural incidence of twins, triplets, and quadruplets. And it's quite handy if a journalist phones you to comment on a quintuplet that has been born, then you can calculate the expected natural incidence, because it's very simple. Twins we expect in 1 in 89 pregnancies, and then triplets you can calculate by 1 in 89 to the second power, so about 1 in 8,000 pregnancies are expected to be triplets, and then quadruplets, it's 1 in 89 to the third power, so one expects them in about 700,000 pregnancies. Now, we know from our perinatal epidemiology data that actually twins and triplets are much more common than we would expect just by nature. And that's because of the fertility treatment. Now, in Flanders, instead of 1 in 8,000 triplets, we see 1 in 5,000 pregnancies that are triplet pregnancies. And in the United States, actually, it's 1 in 880 pregnancies that are triplets. So in the United States, the rate of observed frequency of triplets pregnancies is about 8 times the expected rate. Now, in Belgium, we don't do that badly, and that's mainly due because our fertility treatment is reimbursed, provided that preferentially only 1 embryo is transferred, and that's reflected in the lower rate of triplets that we see. And also, obviously, there's the option for fetal reduction if parents would want a triplet reduced to twin pregnancy. Now, what's the problem with triplets? Now, looking from the baby's perspective, obviously, the main risk is the risk of very preterm birth. We know 1 baby is usually delivered by 39 to 40 weeks. At twins, we are about 35 to 36 weeks, and triplets, on average, they are welcomed at around 32, 33 weeks. And obviously, that's the main cause of long-term morbidity and neonatal mortality. Now, to prevent preterm birth, unfortunately, first we know that cervical length screening is not so sensitive in a triplet setting, and also there's no proven efficient measure to prevent preterm birth, and that's also the reason why we don't recommend routine cervical length measurements apart from research purposes in triplet pregnancies. Also, besides the risk of very preterm birth, we also know that growth is less well. The babies don't grow that well in a triplet setting, especially if mom it's her first pregnancy. Then we see most growth problems occurring. And so the ideal mom to carry triplets is a woman who already had a successful previous pregnancy or successful previous pregnancies. And that's an issue, of course, because like Asma addressed, and in triplets, we calculate the growth discordance by just taking the estimated fetal weight of the biggest baby and taking the estimated fetal weight of the smaller baby and divide it by the estimated fetal weight of the larger triplet. And we know that about 1 in 3 triplet pregnancy, the discordance is more than 20% or 20% or more, which is the discordance that is significant in the twin setting. And in about 1 in 10 triplet pregnancy, there's even more than 40% difference between the bigger and the smaller triplet. And yeah, it shows that actually if it's a first pregnancy, that it's very difficult for the womb to accommodate 3 babies at the same time. And we see that growth is usually similar to singletons up to 28 weeks, but from 28 weeks onwards, we see that the growth velocity declines. And if they are delivered at 35 weeks on average, triplets will be growth restricted according to singleton standards. And that's logical because the bigger the baby gets, the more it needs and the less likely the womb is able to provide and accommodate the needs of these babies. And taking severe preterm birth and growth problems together obviously increases the risk of ending up with very small babies, extremely low birth weight babies, defined as babies weighing less than 1,000 grams at birth. And that's a major risk factor, obviously, for neonatal mortality and morbidity and long-term handicap. And these are the statistics. We know that the risk of perinatal mortality is 10 times higher in triplets. It's 7% in triplets as compared to singletons, where it is 0.7%. And obviously the risk of cerebral palsy, which goes together with extremely low birth weight and preterm birth, is 25 times higher in a triplet setting. 1 in 500 singletons is diagnosed with cerebral palsy, whereas it's 1 in 20 triplet infants. Now, there's not only the babies, there's also the mother carrying these triplets, and obviously from 24 weeks onwards, all triplet pregnancies will experience in increasing manner physical discomfort. Obviously, there's a need for cesarean delivery, and it's usually offered by 35 weeks, if not yet delivered beforehand. Now, the reason why we don't attempt a vaginal birth under normal circumstances in a triplet pregnancy is because in only a minority, the babies will be in a good position for a vaginal birth, and also from studies we know that the likelihood of achieving a successful vaginal birth is quite low in a triplet setting, and also probably the risk for mom of having major hemorrhage is also increased. So usually we offer cesarean section, and we don't go beyond 35 weeks because we know that the risk of in utero demise is decreased after 35 weeks. So we offer delivery at around 35 weeks. We also know that there's increased risk of preeclampsia. Actually, the risk is 6 times higher of severe hypertensive disorders in triplet pregnancies, especially if it's a first pregnancy and in older women. So we use the NICE guidelines to start low-dose aspirin in the first trimester. So if it's the triplet pregnancy is a first pregnancy, or mom is more than 40 years old, is obese, or there's a family history, or more than a 10-year interval, we start low-dose aspirin in the first trimester. And then something that is often overlooked, but I think is also very important, is that there's an increased risk of major complications around birth in mother. 1 in 25 triplet deliveries will result in major obstetric hemorrhage, which is defined by the need of more than 4 units of packet cells, or intensive care unit admission, or peripartum hysterectomy, or embolization, and other life-threatening morbidity like uterine rupture, ICU, admission, eclampsia. So it's also a threat. A triplet pregnancy is also a threat for mom's health. And actually, the risk of maternal mortality is 10 times higher in triplets than in singletons. And then, not to forget, and that's I think one of the major issues why parents opt for selective reduction, it's the financial and emotional burden to look after 3 babies at the same time. So I think if parents embark on a triplet pregnancy, for the team that looks after these women, it's very important to make sure that there is an adequate network around these patients to support them in the early postpartum period and early infant years. And this is from the tabloids. I think, it's a typical triplet pregnancy because most triplets are the result of fertility treatment. So these patients are really happy after a long period of trying to conceive that they have this option of having an instant family. But this lady, she actually, her marriage broke up because she underestimated the strain to look after 3 babies at the same time. As she was a very bubbly personality before she had her triplets, but then she became like a machine, just sterilizing bottles and feeding and changing nappies. And obviously, if you're looking for a babysitter and you want to go away, she couldn't find anyone who would look after her 3 babies. So, I mean, it's not to be underestimated the emotional and social impact this has on families. Now, just what type of triplets and how do we talk about triplets? It's the same like for twins, basically. So you can divide them into looking the number of placentas per baby into trichorionic, and these are the most common triplet pregnancies. And dichorionic and monochorionic are much less common. And then according to the amnionicity into triamniotic, diamniotic, and very, very rarely monochorionic, monoamniotic triplets. And obviously, the more the babies share, the more likely these are the result of spontaneous conception. But unfortunately, they also have increased risk of adverse outcome because of the possibility of intertriplet, I must say, transfusion imbalances and risk of cord entanglement. The most common type of triplets are the trichorionic triplets, and just to summarize their outcome, we know that most are after fertility treatment. Actually, their survival rate is not that bad. It's about 90%, but like I said, there's a 30% chance of delivering very preterm, and actually 1 in 20 chance of delivering extremely preterm. Now, for the management, so every patient that has the diagnosis of trichorionic triplets, obviously there's the first trimester scan where we look for structural anomalies as well as we can, and also do the risk assessment for Down syndrome, because to my knowledge, I know that there are companies that offer it for triplet pregnancies, but I checked the literature yesterday and I don't find any data. So as far as I know, NIPT testing is not yet an option in trichorionic triplets. But then importantly, in the first trimester, we also discuss the option to reduce, and then usually from 3 to 2, from a triplet to a twin pregnancy. And we explain to parents that this reduces the risk of very preterm birth from 30% to 10%. So the absolute risk difference of 20%, which means that you have to perform 5 reductions to prevent 1 very preterm birth. But this comes at an extra risk of miscarriage of about 3%. So in unreduced triplets, the risk of miscarriage is about 5%, and after reduction, it's 8%, which means that you have to do 30 reductions in order to cause 1 extra miscarriage. So the follow-up scheme is a little bit the same like in dichorionic twin pregnancies, because we see them every 4 weeks from 20 weeks onwards, but a little bit more frequent towards the end, especially for maternal complications, especially for preeclampsia. And then the dichorionic, usually triamniotic triplets, not surprisingly, they have lower survival rates, like a recent systematic review from Asma Khalil's group demonstrated. and they also deliver earlier than the trichorionic triplets. And that's mainly due to complications of the shared circulation in the monochorionic twin that is present. So you have a risk, especially of twin-twin transfusion syndrome in this monochorionic pair. Now, you can do laser surgery if there is a TTTS, and the survival rates are not, they are actually quite good, but the main thing is that the average gestational age at delivery is 3 weeks earlier. So if you do laser in a dichorionic triplet, they will deliver on average at 29 weeks, whereas it's 32 weeks in a monochorionic twin setting. So for our dichorionic triplets, we still use the combined, the ultrasound screening, nuchal and nasal bone, and tricuspid regurgitation for first trimester screening. Although theoretically you could do NIPT testing because it's a little bit, they are dizygotic, so it's a little bit like a dizygotic twin. 2 of them are definitely monozygotic, but there are no figures in the literature, and at least in our center, we don't offer it as a screening method. And then for reduction, it's a little bit controversial. I know that centers reduce in this setting from 3 to 2, but in our hospital, we go from 3 to 1 baby. So we use the high-risk monochorionic pair because we feel that by reducing the singleton baby and leaving behind the monochorionic pregnancy does not improve the prognosis very well. But if you reduce to a singleton pregnancy, then you have a significant benefit in reducing the very preterm birth rate. You would need to do 3 reductions to prevent 1 very preterm birth at an extra risk of miscarriage of about 5%. So it goes from 10% in an unreduced dichorionic triplet to 15% in the remaining singleton pregnancy. And then the follow-up is like for our monochorionic twin pregnancies. So we scan them every 2 weeks, although the last scan since we deliver them, the 36 weeks assessment, is no longer necessary because the babies are already delivered at around 35 weeks. But we see them every 2 weeks, especially for the complications of the monochorionic pair, twin-twin transfusion syndrome and TAPS. And then finally, the very rare monochorionic triamniotic triplets. There's only a report on 17 Japanese monochorionic triplets. So I think the figures there are between brackets because they're a little bit uncertain. So it reports higher survival rates than in the trichorionic triplets, which I don't think is the case. I mean, I've seen like 50% that went really well, but 50% that didn't do well at all. Obviously, I mean, they're at risk of twin-twin transfusion syndrome within the monochorionic triplet pairs. And you can do laser surgery like in monochorionic twins, but the issue here is that you have to separate the 3 babies. Like I showed you on my first picture on the placenta, you have to separate the 3 babies because if you separate only 2, then a new imbalance can occur in the ones that are unseparated. So it's a very complex situation. The good thing is in monochorionic triplets that you theoretically can use NIPT, and we do use it in monochorionic triplets because they are monozygotic. And obviously the downside is that you cannot, or at least we don't offer fetal reduction because it would not improve the outcome. You would have to resort for cord or intrafetal coagulation, and you leave then you either go to 1 baby, but then the risk of miscarriage seems to be very, very high. And if you leave 2 babies behind, then they can develop twin-twin transfusion syndrome. So it's either continuing with the triplets or opt for a termination of the entire pregnancy. And the follow-up is the same like in our monochorionic twin pregnancies, except for the last evaluation, and that's no longer necessary because they're already delivered. And then very rarely is when there is a monoamniotic component present, and these cases are very, very rare. Usually, I mean, there's a high risk of demise because of the cord entanglement. And obviously extreme preterm birth because of the triplet setting. And usually there is also a cardiac twinning present in these cases, or a major anomaly. Now, the only group that you can offer selective reduction is this group. It's the dichorionic diamniotic triplets, where you can reduce to a singleton pregnancy. So that's a little bit what I wanted to say about the triplets. So we have to thank our colleagues in the fertility unit to provide us with mainly trichorionic triplet pregnancies. The main issue is very preterm birth, and there's no good solution for that, and that explains the risk of why we lose babies and why they have long-term handicap. And we must not forget mom, who also has a risk of, especially if it's a first pregnancy, if mom is older and if it's after fertility treatment, of ending up with severe morbidity around the time of birth. And the more they share, obviously, the higher their risk. But it remains very nice. This is these are not mine. These are triplets from one of my patients. It was a dichorionic triamniotic triplet, one girl and 2 boys. It remains very nice if you can guide this pregnancy towards a healthy mom and 3 healthy babies. Thank you.
Thank you very much, Elizabeth. Any questions? So while you're thinking, I have some questions from the online, from the streaming. So one question, in triplets, when do you consider short cervix? Do you give steroids routinely, and when?
Yeah, so I don't routinely look at the cervix because it's not very predictive. So obviously I do the lazy cervical scan. So when I do a transabdominal scan, I look in the lower segment. And obviously if you see that the cervix is dilated at around 16 to 18 weeks, then I would discuss the option of putting in a cervical stitch. But otherwise... there's unfortunately no effective intervention.
Do you give steroids routinely, and when?
No, I don't give steroids routinely. I'm a little bit worried also about the adverse side effects in a triplet pregnancy, the cardiovascular burden of carrying triplets and then giving steroids, and so no, and sometimes it provokes contractions as well. So no, I don't give any routine steroids in triplets.
We tend to give steroids routinely before. So the risk of preterm delivery is very high. Yeah. So despite the fact in the UK, the NICE guidelines said that if they are uncomplicated, we deliver at 35 weeks by cesarean section.
Yeah, but then you would consider steroids, but not just like at 28 weeks of all triplets.
No prophylactic.
No. But if you expect delivery within 1 week, then obviously. But that's not a prophylactic. Then there's a true indication to give steroids.
Yeah. Okay. Any other questions? Okay. There's another question. In dizygotic different sex twins, when we have an anomaly, when we have an anomaly of one of them, is it mandatory to do amniocentesis in both, or just the abnormal one? Well, I guess just the abnormal one. Yeah, do you agree?
Yeah.
Because they are different sex, they are dizygotic. Yeah. Well, I mean, unless the parents want to test both, we usually just do amniocentesis for the baby that has a problem. Yeah? Does that answer the question, I guess? Okay, any other questions?